Welcome. Welcome today. I hope everyone's doing very well. I'm at the office. I just finished doing 3 Zooms, whitenings, and a bunch of non-elective work today. Okay, that's my only April Fool's joke for the day. The rest of this will try to be a little bit more serious. My name is Dr. Adam Folek. I'm going to be talking about workflows for success with Chrome. Just a little bit of information about me so you know who that I am. I'm a graduate of Temple School of Dentistry. Went to undergraduate at North Carolina. I'm a big Tar Heel fan. I did an AGD at the University of Mississippi Dental School and Medical School. It's the primary trauma center for the area. And the nice thing about that program was that there were no specialty programs at that time. I think they have oral surgery now. So I was able to do as much surgery and reconstructive work with aesthetics as I wanted to, and it was wonderful help. I was able to place implants back there in '97 and '98, and do a lot of grafting and aesthetic recontouring. So that was very exciting. I joined a practice in Norfolk, Virginia in 1998, and soon after that I took a maxi course so that I could start my process towards getting my credentials. You'll see later on down the line, I'm a diplomate of the ABOI and an honored fellow of the AID. I started on the road by getting my associate fellowship and then fellow and eventually the diplomate. I think the credentials are extremely important in the time that we live in, where we're going with implant dentistry, and to make sure that that we know what we're supposed to do and that the public has a feeling of trust to who they're going to. I went to the Georgia Maxi course, I second in 2002 and started that process. Through the time, I went into private practice with a doctor, and he retired in 2004. He used to teach at the University of Penn Prosperio program, pathology and occlusion, so I got my occlusion background from him. During that time period, I grew what is now the Foleck Center, what we call the Foleck Center for Implant Aesthetic and General Dentistry. Just goes by the Foleck Center. We have 4 locations around Norfolk, Virginia Beach, Hampton area. I've been lecturing on implant dentistry since 2008, all aspects of it. I have a fondness for the digital aspect of implant dentistry and how it all merges together. And but I enjoy doing all aspects, from the placement of implants, the prosthetics, and also working with marketing and practice management. I have served in various aspects of leadership within the AID. I am a KOL for MIS and Chrome. I'd like to let that be known out there. And I do have to say one of the reasons I've been able to push my career ahead is because I had a focus very early on that I wanted to do implants and concentrate on implant dentistry. I grew my practice with the sole impetus of being able to supply more implants to myself through an internal referral source, instead of having to try and ask dentists in the area to send their implants to me when I was already having to fight against the oral surgeons and the periodontists. So that was why we grew the practice. So let you know, our practice is about 75 people altogether. We have about 7 to 8 doctors, and like many of you, we're feeling the hurt of this time, and we had to furlough about 66 and keep a couple of the practices open with emergencies, and that's what we've been doing at this time period. We will all make it through this. I'm looking forward to getting through this. Obviously, it's a financial crunch no matter what the size of your practice. Today, I'm going to be talking about Chrome, but really coming at it from the team's role in the whole process, because there's so many places and steps with this whole, with doing this procedure, that we can lose sight of who's responsible for what and how do we get people to do what they're supposed to do. And I think it really comes back to making sure that you're doing the proper team training. A lot of times we come back from our meetings and we learn a new procedure or a new process, or we're just talking on the phone. You know, I'll be talking to Alan today, and all of a sudden I hear that, hey, we're going to start doing this now. We're going to start incorporating it, doing it a little bit differently here. And I get off, and if I don't let my team know what's going on and how this is going to affect them, then it ends up being a problem when we actually bring the patient in for the actual surgery. So what we're going to talk about is like, what is the role of your team, and how do you define these roles, and who is responsible for these roles? Every step along the way requires some ownership of a certain process along the entire uh, workflow that we have. Now, digital workflows have become a very popular word, and understandably so, but we never really talk about workflows for the staff. You know, I believe that ownership is extremely important, very involved, and they're very dedicated to what we do. But if we don't give them ownership of certain procedures and certain techniques, then they just kind of feel like they can go anywhere. My surgical staff, my team that follows me around to all the different offices, as I said, I go to the different offices and do all the surgery and implants for them, are very proud of being on the team, and they're very proud of what they do. And even for the other doctors in the office, we always ask them to have kind of a niche within dentistry, and they all feel proud to be working with that doctor because there's certain things they do that nobody else really can do. They need to understand the workflow for every procedure that's being done, and they need to know that responsibility. They need to have responsibility for what they do, and they have to be able to pass on that responsibility from that procedure to the next person on the team. So they need to see where their role falls within the bigger picture of all this. You know, when we're looking at this, they need to understand how every one of these procedures works and the goals of that procedure, whether for a single anterior unit or an overdenture or the fixed implant prosthesis. And that's what we're going to be talking about today. There are different steps and there are different requirements. It's not as easily just saying, okay, we're going to be doing an all-on-X case. There's lots of different aspects to every patient and what we have to do within that. Clinically and administratively, every person needs to have some basic understanding of the diagnostic, restorative, and surgical requirements. And this requires you as the doctor taking the time to let everybody know what's going on. If you have a big office, it's sometimes better to have these meetings in sections and say, listen, we're going to do it with this department now. We're going to do the clinical department, and then we're going to bring back the administrative department, and then we'll bring them both back at a different time to see where we're having problems and where we're having our successes. Now, are these roles interchangeable or are they not? I'm not a big fan of, I think that we need to I should clarify that. I believe that our assistants need to be able to do what the other assistants do within our team. And I think that the front needs to do what the front needs to do. I think it gets very difficult if you're asking the front to do what the back does, and if you're asking the back to do what the front does. My advice is, if you feel like you don't have enough people to do what you need to do, then go ahead and hire an extra person. I'm a big fan of hiring extra people when it's time to, whenever we feel like we're falling behind. You know, I think that we have to look at what their goal is and how we're going to do this. You know, I ask each of my team to let them know, to understand their role. Their role as an entire team is to make my life easier. I tell them that at the beginning of our meetings. Their goal is to make my life easier and make it so that I can produce more dentistry and not be a part of the little minutia that goes on a daily basis. And I try to get them to do as much of this and leave me out of as much of it as possible. I want to be with the patient, to meet the patient, to do the diagnosis and do treatment planning. And then for the rest of it, I want to be there the day of surgery. I'm there to help out where it needs to be, but I need to be working on another chair. All of us are a producer in the office. We are not people who need to be part of the of all the little aspects of it, knowing the codes and being part of what the front desk is doing. As soon as I'm finished with a patient, I'm on to the next patient, and I expect my team to pick up all the slack in the meantime. And finally, we need to have a rapport. The rapport that needs to be with the patient is tremendous. And we always talk about this, and I know this is stuff that you've all heard before, but the rapport with the patient isn't just when you meet the patient the first time. That rapport has to be transferable. What I mean by that is the person who is seeing the patient initially, your treatment coordinator, the new patient liaison, needs to be able to pass off that patient to the next person with all the information and let the assistant who's going to be doing the work or the front desk who's going to be doing the case acceptance understand all the different aspects of why the patient is here. So what's the role of your team? Is really make your life easier, as I said. Reduce the amount of time that I spend with my patients doing the immunization. It keeps me out of the weeds. I don't want to be involved in all the scanning. I don't want to be involved in taking the CBCTs and putting fiduciary markers on dentures. I'll be in there to do the clinical aspect of it, the diagnosis, I said, and treatment planning. The goal is to make each procedure in the entire day more profitable. Once your staff starts doing more and more of this, they get a certain amount of pride. They don't like to give it up. They feel that they're now an expert in what they do, and they feel that they're a valuable commodity. And we have to treat them that way and remember that they are that. So what is your worth to the office? You know, it's very important to find out and make your staff know what your worth to the office is. Your worth to the office isn't what you hope to produce on a daily basis. It's not what you hope to produce in the month. I take the reports at the end of the year. We take a look at the collections from the year, and we divide it out and figure out what my worth is to the office on a minute basis. Now, why do I do this on a minute basis? Because I do not want the team to think that it is acceptable for me to be standing around doing nothing. Every time that an assistant is leaving the room to go get the Nomad machine, to go and pick up some graph material that they forgot to bring in, or do anything that leaves me standing, each minute costs the office a certain amount of money. And the entire office knows my worth and knows what it's costing them. And a lot of times just a minute are more than what the assistants or the hygienists make within an hour. So it's really important to know what it is. Don't be upset about it. Let the staff be a part of it, and let them feel that every time that they're causing an issue, they're a problem, and they're not prepared, it's costing the office money. So which roles are interchangeable? We talked about what's interchangeable and what's not. We have our administrative. I do not think that the clinical should be doing the administrative, and I don't think the administrative should be doing the clinical. However, we have an interesting person within our team called the treatment coordinator, the treatment liaison. This is the person who actually who interviews the patient, gathers all the information, starts to build that rapport, starts to find out everything, why the patient is there in the evaluation process. And having an assistant do that takes up time where my assistants should be helping me do productive work. So my assistants they know what they're supposed to do, they know how to do it, they know how to make me productive. But if I take the time to take a treatment coordinator, an assistant as a treatment coordinator, that's a procedure that I possibly might not be able to do. So we take the best person who is good at working with the patient, sitting down and taking the time to go over everything, teach the patients how to read CBCTs, know what to expect, go over models of bone attrition, go over before and afters, get the patient ready for me. And then we are able to go ahead and she's able to go ahead and pass the baton off when it becomes time for the assistants to start gaining the diagnostic role. This treatment coordinator could be an ex-assistant, could be an ex-hygienist, or it could be an ex-administrative person. It depends on who's best for that position, and you have to take the time. That person who does the treatment coordination has to be able to be somebody who is can take x-rays, though, and is x-ray certified, and understands what it is to take an impression, and possibly have a knowledge of some of the financials that go along with this. They don't have to be perfect in each of them. They're not doing all of those roles, but they might be asked upon to sit there and apply for a care credit, or they might be sitting with the patient and asked to take an impression or a CBCT. And again, this rapport, as I mentioned before, is super important as far as what we're trying to do when we establish with the patient trying to develop that connection. And a lot of times I've seen in the past where that connection doesn't really get passed over well from the initial person who's meeting with the patient. A lot of times when we go to the financial office, in the financial office, we're just dumping the patient in there, or we go to the financial office and we tell them this is what they want to have done. They run the numbers and that person is sitting by themselves. I'm not a big fan of the person ever sitting by themselves. I think we need to include the financial person and let them know what's going on. In fact, whenever I do my actual treatment plan, the financial person who's going to be doing that, whether it's the treatment coordinator because she's versed in doing it, or the finance officer, they will come into the room while we're doing the treatment plan. So it doesn't have to be relayed back from an assistant back to the financial person, because a lot of times things get missed, graphs get missed, different steps within the appointment might get missed. And we need to make sure that everything is heard, and it's always heard best from the doctor when they're delivering the treatment plan. So the next things we're going to talk about now are what I have are the workflow for the steps to surgery. And we're going to take a look at the evaluation of the patient, the acceptance process, then the staff workflow, the pre-op, the surgery, and the post-op. Now, a lot of you are doing what I'm talking about, and hopefully you're able to pick up some pearls along the way. If you take notice, evaluations, staff workflow, and pre-op are in red. They're in red for a reason, because these are places that we can have problems. Acceptance and surgery are in green because these are places that we consider success. And post-op is kind of in black because at that point, I know all of you have done the surgery, you've delivered your PMMA, and they come back and the patient is happy. So I'm not really concerned about that as being a success or not. I think that we're all going to be getting success when we're doing this. So and that's the goal with the way this is set up. I do think that it's important when we're pushing these procedures. And when I say pushing, when we're recommending these procedures, I always use the word guided surgery. You can use prone guided or guided, but it differentiates what we're doing, because when our patients ask us about the cost, a lot of times they're going to come and say, well, I heard from over here it's X amount, and I heard from over here it's cheaper here, or it's more expensive here. How do you justify the cost? Well, you don't like to sit there and justify the cost, but this is something that the entire staff needs to know. And usually the finance office gets this question. And what I want everyone to understand in my office is that this is guided. This is more accurate. This is giving us less time in surgery. We do a lot of these surgeries within just a couple of hours, delivering the final set of teeth. I mean, the PMMA, the fixed teeth. And it makes the procedure much easier for us and for the patient. You can do this for less money for sure if you have somebody who doesn't do it guided. But in today's society, why would you do something that's not as accurate if you can make it more accurate? And again, this is something for our entire staff to be pumping into the patient and letting them understand what's going to happen once we decide this is where that we're going to go. And to let your patients know from the very beginning, the doctor you're here to see today has done everything they can out of the latest in technology to make sure when they plan these cases out, and they plan these cases out with knowing what the end result is before we ever get started, you're going to have this done in the most accurate way that we know out there. So I mentioned the acceptance and surgery are in green. Why? Because let's talk about, this is the time where we know we've got the money coming in. I tell you what, my front desk and my finance officer, when they come back and they've got one of these our patients to agree to doing a Chrome case, a guided case, an implant case, a big case, this is what this is how I visualize them in the office. They're high-fiving each other, which I love to see. They're excited for their patient. They're excited for what's going to happen. They're excited for all the production that we're going to be able to collect, and they're able to collect that money very efficiently, and they do a wonderful job of it. The day of surgery, when we come in, we're all set up. Here we go. Our surgery goes on. It hopefully goes as nicely as possible. If there's any hiccups, we deal with those. And then we're done. We walk out of the surgery and we say, wow, that was great. We had these nice guides together. Everything flowed the way it was supposed to. We got the patient with their teeth in their mouth. It looks great. And we're all excited about it. However, the evaluation, staff workflow, and pre-op. These are the places that I've noticed in my practice. And the reason I'm talking about this is because I've had this happen more often than not, is where we end up losing money and all that wonderfulness of getting the case accepted, the patient on board. We're just throwing money out the window because it requires extra steps. Yesterday, Joe talked to us about the different steps involved in determining VDO and making sure they have the right pictures and making sure that the right information is sent to them. Every time that we have to stop something and that we have to get on the phone with the lab and reevaluate. It's going to cause, it can cause problems with the patient, their surgery date. We might have to bring them back for extra appointments. And every time that we're having to go back and see the patient for things that we should have been able to do, whether it was at the initial appointment, the evaluation aspect, or even at the pre-op aspect, then it's costing us time. Just remember, once you're able to figure out your worth per minute, all of a sudden, every time you're seeing an extra patient, that's what it's costing. I'm not as worried about the patient being in the chair. In fact, I've heard in the past that the chair time is so expensive. How much the patients in the chair is costing me money. I don't believe that's the case. Now, I don't have an MBA, but my feeling is as long as I'm working and doing something productive, if another chair is with my assistants and they're doing an iJig or a fixture level impression or a scan or something that's helping me to get the process going and I'm still able to be productive, well, that's actually better for me. I'd rather have 2 or 3 chairs going where I'm not working and I have other people doing the work for me for these cases. And we're seeing maybe another chair where we're doing the new patient interview and getting the diagnostics for that. And in the meantime, I'm doing work. So this is where I see the problems occurring, and they've occurred for us. And we've tried to develop different workflows for this. So with evaluation, again, I'm just going to go over very briefly. I know you all do this, the medical review and health history review, but who really does this? It's the person who's doing the intake. And we need to teach them to recognize red flags, because we all know that their intake is probably not as going to be as in-depth as our intake, and it's not going to be as rigorous. And these red flags should allow us to go ahead and ask more questions in depth. And it's very important that you sit down so they understand what these different conditions are. We have medical conditions that obviously they're going to be red flags for us, diabetes, COPD, cardiac, autoimmune disorders, and a bunch of other things. But we have to make sure that whenever these are brought up, that our staff understands what these are. I've found out years ago, my staff really didn't even understand what a blood pressure was, what the systolic and diastolic numbers meant. They didn't understand what diabetes was. And at team meetings, I would have a group of, I'd pick 2 people, one person from the front and one person from the back, and they'd have to give a 5-10 minute PowerPoint on what these conditions were. It made everybody much more aware, and they were much more cognizant when these issues came up. Medications, obviously, the blood thinners, bisphosphonates, blood pressure medications, and a slew of others. We have to keep up with them, but they also need to know what these are. The blood thinners are coming out in different names all the time. And you might go back to the generic names, and the patient and the assistants might not recognize these as being generic, and they just remember the actual name that the manufacturer gave it to originally. So, you know, we need to make sure that they recognize these red flags. And obviously, we want to make sure that any allergies are noted and taken care of. And it's then our job to come in and take a look at this and go forward from that. The need for a medical consult is so important, and when we discover any issues that we need to consult the physician with. Now, we do the majority of our cases under IV with an anesthesiologist, so we get these consults most of the time anyway. But even with the smaller cases, we want to make sure, and along the way, there's going to be a few appointments until the patient comes back. Usually, you want to make sure every time that the medical consult has been done, because you don't want to get there the day of surgery and all of a sudden realize you haven't gotten the proper medical consult. You don't know what the A1C is for that person. You're not sure why the patient was eating on the day when they shouldn't have been eating. So all these things need to happen. We need to make sure that the patients are taken care of properly and that we have our backs covered by the physicians. Dentally, we need to know why they're here. Obviously, this is the chief complaint. I hate the word chief complaint. I don't think it sounds right. I think we want to know why they're coming to us. Okay, let's just find out why they're here. What was the impetus for bringing them there? And what's their end goal with all of this? What do they want? And how do they expect it to happen? Is their goal a value goal? Are they about budgetary? Are they about function? Are they about aesthetics? Is there a mixture of that with them? We need to find that out and make sure that once we know that that's what we're addressing, and that's part of the rapport when we're passing the patient on from person to person. And finally, how did their mouth get like this? Their dental history. This is kind of a, I found this to be one of the most important questions because this is what really establishes rapport. When we see a young girl in her 20s come in like this, and she's got decay everywhere, she's missing teeth, she's got some restorations with decay around them, some recession going on. You can see infection there. You take a look at the x-rays, there's infection. How did she get like this? One of the worst things that I hear from patients recently has been that I was told by my doctor that I had a meth mouth. And they said, and they emphatically deny it. Now, whether they deny it and they're true or they're not, we don't really know. We can only accept the truth from the people who tell you that that's the reason. But there might be other conditions. Maybe they just didn't take care of them. Maybe they grew up in a rural area, which we have around here. And, patients get very upset when they feel like the doctor is insistent upon this. And that's kind of a catchy phrase right now within dentistry to tell patients if they're young and we see a lot of decay that they have a meth mouth. I'm more interested to hear what they have to say and to get them to open up. And a lot of times they'll take responsibility for themselves. And that's what we're looking for, because we are going to give them a lot of responsibility by giving them this procedure. I always tell my patients, listen, if you're going to agree to this, I need some reassurance from you that you're going to come back every 3 months for hygiene, that we're going to be able to, you're going to take care of this properly. You're going to follow all of our instructions from the moment you leave here after we do the procedure till for the rest of your life. This is a lifetime commitment. And I kind of get in their face a little bit about it in a nice way, but I want them to realize that we have their backs as long as they're going to be taking care of it. And now it's time for them to be responsible for what's going on in their mouth. And then then it's really up to the treatment coordinator to start to sell the case for us, before and after pictures, getting the models going of what the jaw looks like when it loses teeth, and this is what we do to start making sure that everything happens in the right way. Obviously, with the doctors, it's our responsibilities to do all of these things: extraoral and intraoral examinations, FMX, CT. I'm not going to go into a full explanation of all this. You know about this, and that's for another lecture. The full set of pictures, it's our job to make sure that these pictures that we're taking, that we want to send to Road, we do this with all of our patients, with different aspects, that they're a good picture. No matter how much I try, my assistants sometimes have some issues taking clear pictures, and we do need to make sure that the pictures are what they need to be, so that the lab gets what they need, and also we're able to show nice before and afters. I'll show you some pictures later on that I wasn't paying enough attention to them, and they looked good, and then when we blew them up with the computer, they weren't nearly as clear as we needed them to be. And obviously, we're the one that has to be in there to give the treatment plan. So just very quickly, whenever anyone's coming in, I know they're a terminal dentition, I'm going to tell them that they have 4 options, and I'm going to go through this as quickly as I go through it with my patients. And one is, obviously, we have to tell them to do nothing. The other is our traditional removable, where if we have to extract teeth, they're going to get an immediate denture. And within a year, they're going to need another denture just because of the resorption of the bone and the shrinkage that's going to occur within their mouth, and how loose that denture is going to be from the moment we put it in. I never sugarcoat how nice dentures are going to be. I'm going to tell them that they need to have glue ready at all times, and that we are going to do the best we can to give them the best denture possible. But we can't guarantee that these things are going to stay in their mouth and they're not going to act like real teeth. And then we go into our implant-supported prostheses. And this is what the patients are really coming to see us about anyway. And we have the 2 options. We have the removable options, and we have to go over the removable options, implant-supported removable options, whether it's to the bar. You're going to use some sort of locator attachment for an RP5, or you're going to do a bar like an RP4, or a conus type of abutment, which is really an RP4 prosthetic. And then we have our non-removable. I don't like to use fixed. I don't think patients understand fixed. I think if we say removable and non-removable, it's very easy for them to understand. And I don't go over FP1, FP2, and FP3, but with the patient in depth, we describe what that is, and our assistants know it, and then we're able to transfer that over to the financial office. Now, why is this important? Well, we need to know what these are. The FP1 restorations replace the clinical crown, and they look like the natural teeth in size and contour. Joe talked about this yesterday. I have a little difference of interpretation of the FP2 according to Carl Misch. These are restorations that replace the crown and a portion of the root. The teeth appear natural at the occlusal and incisal half, but they're more elongated or hyper-contoured at the gingival aspect. These are when you can see the roots of the teeth, or you have really long-looking teeth in a patient that might have a low lip line. And the FP3s are going to be restorations that incorporate pink into the prosthetic and replace the teeth in the gingiva. So anything with pink is automatically an FP3 in our office. And when I talk to lab, that's what I expect. And I mentioned that to the technicians when I'm talking with them on how I want things to be. Joe mentioned there are these the Chrome Natural, which we're starting to do, and these are an FP1, maybe an FP2 situation. I love these because I think there's a great place. We don't always have to be removing a lot of bone. We can just remove the implants, recontour the bone around the implant, and remove the teeth, excuse me, recontour the bone around where the implants are placed, place the implants, and get a very natural FP1 restoration. The importance of this is that Chrome Natural is going to be a little bit more expensive and the parts are going to be different. So we need to know how to charge that in. And when we send the patient back to the finance office, if we show them pictures of what it's going to, an FP1 versus an FP3, and they choose the FP1, or they're only a candidate for the FP3, the financial office needs to know what to charge and how to charge it in. So for the acceptance, you know, every one of us believes that the patient is ready to accept before they go back to the finance department. In fact, we always go back and say, so what did they say? When are they scheduling? And we're always disappointed and don't understand why they didn't agree to do it, because they seem so on board, and then we find out they had no money at all. This is something that all of us go through on a daily basis. But this is where the cases are closed, and they have to be just as involved with the process and understand the patient's rationale when in the finance office as the back does. And it's really important that they are just as excited. That's why I bring them into the operatory, or I take them into the finance office to go over the treatment plan with the treatment plan coordinator there, or the finance officer there. I think that's extremely important. Now, once it's accepted, it's game on for the team. And this is really where the staff workflow becomes important for Roe and the Chrome the Chrome workflow and what we're going to be doing when we're working with the tech. More mistakes are made, I think, from the moment of acceptance to surgery than doing the actual surgery. We all know how to do the surgery, and we all understand how the prosthetics work. But this is where things happen that are going to cost us time and money. There are many moving parts, and any missing step can result in various reasons for delays. So, now, I presented this as a staff workflow for my assistants, and I can actually send this to Alan and they can put it up. We actually have just workflows for the assistants that go through this in very fine detail of what each person's part is. I'm going to go through in a little bit more detail with you. Immediately after the case acceptance, the financial coordinator informs the assistant. We try not to let the patient leave. We're going to bring the patient back to that room, which means that room cannot be cleaned up and should not be scheduled for somebody else. Okay, that's what I was saying about rooms. The importance of rooms are so that we can use those to be doing other procedures while we are the ones actually doing production. The assistant then has to gather all the pertinent diagnostic information. This all depends on what we did and said while we were doing our diagnosis with the patient. So the patient has to, we're saying, but the assistant in financial office also has to understand what steps are going to be involved. The intraoral scans of both arts with the bite and centricalization and our impression of both arches with the bite registrations are taken by the assistant at that point in time. I will go in to verify all bite registrations and make sure that they are correct. I think the doctor needs to do that. You cannot rely on your assistants to do this. A lot of times the patient is having the assistants have a hard enough time figuring out where the bite is supposed to be. And it's at this appointment that the doctor decides if an orthotic is necessary or printed trident is necessary. And if so, then we have to let everyone know that there's going to be extra appointments before the patient can be scheduled for their final surgery. And, you know, I don't like to upload any of the information to Roe until I have all the necessary information ready. Now, if they're making the orthotic, that's one thing. If we're doing ourselves, if we're designing some sort of partial to help support the occlusal, the opposing occlusion, then we have to do that ahead of time. So all this needs to be relayed to the staff and then eventually to the lab that we're working with, Roe Dental Lab. We take a look. We have a patient coming in here. She has a nice big smile. We take a look at on the left-hand side, you see her smiling very big, and on the right-hand side, you can see the teeth in occlusion. We have to decide, is this going to be a patient that we need to open up? Do we feel good about where the bite is? Do we feel confident that we need that this is going to be acceptable for her in this position? And do we need to have some sort of printed try-in to be done beforehand? Or do we feel comfortable that if we talk to the lab, opening it up just 2 millimeters might be enough with the reduction in bone, that we're able to go forth and we feel confident that we're going to look at the design, the prosthetic design that the lab has come up with. This was one of our first cases that we did with Roe, and sorry about the quality of the pictures here, but if we take a look, you can see a reduced vertical here. Take a look at the bottom right-hand corner, you can see that canine is super erupted, and while as well as the bone that's coming down on the left-hand side. So we're going to have to decide what the what we're going to do as far as getting the patient into the right vertical for the lab. So if we're going to, at this point in time, we decided to do some sort of mock-up so that we could start to establish a new occlusion, and then we could send this, and working with Roe, send this back and scan this in and start to determine where the patient needs to be. We can also see in the anterior and the lower anterior that we are going to, those teeth are very mobile. He would not let me remove any of them. That was the big problem. So that when those teeth are removed, he's all of a sudden going to collapse in a little bit more than what we have right now and reduce our vertical. All these things need to be taken into consideration, but the staff needs to understand what we're doing along the way. They can't just plan the patient's surgery since we have extra appointments, which are necessary. This patient came in on the right-hand side. This is her smile from 12 years ago, and we didn't see her for about 12 years, and she didn't take care of herself. We can see that she has a higher lip line and a gummy smile. How is this going to change what we do for her? And where the transition line is, how much bone are we going to have reduced? Or in a case like this, is this a wonderful case for an FP1 and maybe that chrome natural? We don't have to reduce that much bone, just take the teeth out and put the implants in the ideal position. And this is where our FMX has become so important, that we're able to evaluate the amount of bone around the teeth right now, and if they have enough there, then maybe this is a situation that we're going to use the chrome natural case in, rather than removing a lot of bone and risk having a high lip line, especially a hyper lip line in somebody who doesn't look like she's smiling high enough right now, but when she gets that prosthetic in place, she might be showing the transition line, even with the reduction of up to 17 or 18 millimeters from the implant platform to the incisal edges. So again, this becomes a part of the process. If that's the case, then again, our entire staff needs to understand that. We take a look at this patient who I just finished doing an online consult with. This is going to be a natural case. It's a patient who has severe decay around her restoration. She's got perio issues going on, teeth breaking down, and she doesn't want to have any sort of crown and bridge anymore. She's tired of it. You take a look at the upper right-hand side. This picture is not a good picture for Roe, though. If you take a look, we had to bring the patient, I took a look at the pictures, and I got him to go back into centric relation and MIP here. And if we weren't paying attention to these pictures beforehand, Roe would have called me up and said, listen, you need to bring the patient back in. I need a new bite. So again, this saved us having the patient come back in and one of my assistants having to sit back and get just pictures, something that's not necessary. Again, we're taking a look at our FMX here and deciding that this is a wonderful case for a chrome natural, because we don't want to remove bone in a situation like this. Obviously, there are plenty of situations where the patient is deficient in bone, where the removal of bone is minimal, and an all-on-X case is going to work out to our advantage. Now, again, with this, our staff workflow, if it's an edentulous area, they have to know if we're going to have to reline the denture, that the denture is loose, or if we're going to be able to start taking our CVCT right away with the fiduciary markers, or if we have to remake the denture. If we have to make a denture for the patient, that's going to add several different appointments. So you cannot schedule your patient 4 to 5 weeks out. You have to incorporate that into the process. And again, the financial office needs to know that before the patient ever goes back, that we're going to have to make a denture for the patient for this situation. It's very important with our scheduling. Now, for us, in our office, we try to schedule patients once we're sure that we have all the information necessary for 5 weeks out. I feel 5 weeks is usually safe with Roe, with what we need to do and to get everything expedited. So this is where it starts. The front desk knows after they're finished getting all the diagnostic information, they go to the front, they schedule the surgery for 5 weeks out, okay? Very important. Immediately afterwards, the assistant goes to roaddentallab.com, starts uploading the pictures and the DICOMs and all the basic information. They then go to me and bring me over to the computer, literally bring me over to the computer and make me fill out the rest of it so that we can upload that immediately. Okay, you can't let that sit around. You have to do this right away. The front desk schedule, and as soon as that happens, the assistant goes to the front desk, and the front desk knows that everything's been uploaded. They will then schedule an online appointment between myself and Ro. And what then happens is they schedule a 30-minute appointment per arch. If I'm doing a double arch, I'll take a full hour because that can take time, with the name of the person who will be leading the consult and the date of the surgery. This has to be clear time. It usually occurs in what is the lunch hour, even though a lot of us don't take lunch. You have to have this as clear time and time to set aside to really go over everything in depth and make sure that the implants are placed where you like them to be, the prosthetic design is what you want them to be, and to make any changes at that time. It's also important that they will ask us the date of surgery. Now, a tidbit for you, whatever the date of surgery is, I always tell them at least 2 or 3 days earlier than the date of surgery. Why do we do that? Because the case gets lost in shipping, or we're going to need time for the pre-op anyway. This enables us to avoid any last-minute rushes. And believe it or not, I've had tons of these, and I'm sure the people at Roe are sitting back there shaking their heads knowing what's happened in the past. But we're trying every day, trying to do things to make it a little bit easier. Any changes to the surgery date after that online appointment need to be relayed to the front desk and the patient informed immediately after the phone call. Don't sit there and think that you're going to remember to do it later. This has to happen. Otherwise, we forget things, and it disrupts when the patient comes in, the pre-op appointment, and the expectations of the office in general. It also makes it look like your office is not organized properly. The email confirmation with the implant parts needs to be sent to the doctor, and I always have them send it to my head surgical assistant and sometimes my other assistant. It is his or her job to order all the parts sent in that email, and it's our job to make sure that any extra backup parts are present. So if you have a 4.2 implant and you want to make, and it's by a 11.5, you want to make sure you also have a 13. You want to make sure you have a 5.0. You have to decide what extra implants you need, MUAs, accordingly, that you have in your office, so that in case something happens, in case the bone is too soft, in case you have to go a little bit further in length, you're able to do that without compromising the PMMA and the support necessary. It's the head surgical assistant's job to check the case when it comes in and make sure that all the guides fit into the bone reduction guide, and make sure everything clicks in properly and that everything is there in that box that we get from Roe. Extremely important. Now, if you take a look, this is the list I got for a patient I'm going to show you at the end. We did the surgery on, and take a look at the top. It's coming from Bushra, and it has my name, Mary's name, and Rachel's name. Rachel's our head surgical assistant, and Rachel is in charge of my team. So they both get it. It says on there, you will need to order the implants, MUAs, temporary cylinders, and 2 of those, an extra set if we're going to use the rapid. So they need to make sure all of that is taken care of. And then when you open up the attachment file, they will see the size of the implants. They'll also see the implant abutment angles. They'll also know that they need to have straight and 30 degrees available just in case something happens. When the case comes in, it's the head surgical assistant's job to check the case and make sure that all the guides fit into the bone reduction guides, that the head surgical assistant also reviews all the notes made during the online consultation and make sure there's any extra materials that are ordered, whether it's graft materials or anything else that we talked about, the type of fixation pins, the pickup material, quick up, any of that stuff. And the patient has to, and at that point in time, the patient usually comes in right around that time for their pre-op. And they're going to come in, they're going to try on the clear guide that goes over the teeth or the soft tissue to make sure that it fits. If it doesn't fit, it's kind of, this is the point where I usually will either send it back or adjust it, see if I can get it to fit. And then we have to make a decision at that time whether we want to go forth or not. In my opinion, I don't go forth. I can't tell a patient we're going to do it free-handed after I've extolled the wonderful aspects of it being guided. And then also we have to review consent forms, go over the consults, make sure we got everything done, the pre and post-op instructions, and review the medical history one more time to make sure everybody's on board. So this is what happens when our assistants, they take these pictures for every single case, they take a look at everything, and one of the things we want to make sure of here, and they know to do this, is to make sure that none of the plastic pieces are broken that go into the bone reduction guides, and the holes are patent. So they'll place this over the top of the model to make sure it fits, to make sure that the windows go down and cover the teeth properly, so that I know how it's supposed to go down over on top of the teeth, and make sure that there's no issues with the fit of this. I know they do this at Roe, but there's nothing wrong with doing a second check. I love to see this model and see how much bone is going to be reduced, and they have this available for me to take a look at how far back I'm going to need to take that bone reduction when we're doing a case like this. Again, we're taking a look at the bone reduction guide, making sure that the little Swiss locks work. The plungers move in and out very easily. These new blue cap ones work very well. And then we start applying the different appliances on top of the bone reduction guide, making sure they go in and out without any issues. Okay, here's our osteotomy guide, making sure that it goes into the bone reduction guide, no problems. Make sure we have nice contact there. We're doing this again with the our transfer guide for our PMMA, making sure that fits properly, also for our rapid. And for the final prosthetics, getting everything lined up and making sure everything sits on there nicely with the columns and making sure we don't have any issues. They go over all this and then they'll sterilize this. For any maxillary case, I always have a backup denture just in case. I've had 3 cases in the past where the bone was so soft we were barely able to get 20 on the tightest implant, and I decided it was in the patient's best interest to go with a maxillary denture. Not having this, I can't imagine what I would have done or said to the patient afterwards. And I always let them know this is going to happen. Another quick pearl for you. This is our patient action form. The doctor-staff communication is huge. I was tired of hearing the he said, she said, they told me something, I gave them an answer, they didn't hear it, they never got this to me. We have patient action forms. This goes to me, I have an inbox and an outbox. Every day I have tons of these. These are for me to either look at CBCTs and plan out cases, to make sure that I have everything ready for a call, to look over a lab case. The lab called about this, call them back, and it had the lab's name, the person who called, their phone number. At the end of each one of these, I have to sign off on it at the bottom. I have to say if there's any extra notes that need to be done. I put when I completed it and the date, and I return every single one of them. I have to do this by the end of every day. I instituted this on myself. It's made things so much easier in our entire office. The flow of everything works much better, and no one can complain if I haven't done something unless I did not return one of these. So now we have the, instead of our GSI report that we would normally get, we have this wonderful screen that we're poster board that comes with our cases now. And this is what we just did a case about 3 weeks ago before the COVID. And this is wonderful. We put this up behind us where I'm working. I used to have a piece of paper with all the implants and the sizes written in big numbers and letters so that I could see the position of everything because the reports were so small. If you take a look at the top, you have the notes on the case. We're going to have to extract number 5 and 12 prior to the pin guide. And the assistants let me know all this. They let us know what's going on. You can also see the angulation of the implants and what everything's supposed to look like. You can see the tooth position, the implant size, what implant type we're using, and the guide drill. And it'll also let you know about the multi-units. I love this. I think it's wonderful. This is our surgical lot that's set up beforehand. We have the computer screen behind us. This is where I used to hang the notes for what I was doing. Now I just put this behind me. We have the patient sitting in front of that 12 o'clock there in our surgical suite. We have another computer on the other side of the patient that we can use also. To the side, we have our, obviously our instrumentation, the PRP machine, but also you can see our robots is always set up and out. They have everything out ready to go. They know where it needs to be. We have the pickup material. We have everything ready so that we're able to have a nice procedure. So I'm going to go over a quick case. I know my time's almost up here, but when you have a patient like this and they don't smile much, this is the patient we looked at beforehand. We had to try to make her laugh. That's when I usually have to come in and try to make someone smile by giving a goofy joke. This is the young girl who came in and she had her dentition, that everything was kind of failing on her. She had an infection, she had decay, she had mobility, and she was ready to make a change. She's getting ready to get married. Her life's on the right track right now. and this is the day of surgery. So she's coming in. We're doing the try-in of over the teeth to make sure everything fits properly. We're then going to go ahead and remove our reflect the tissue back here, making sure we reflect enough of the tissue, and place our guide over again. This is where we've done the extractions here. Now we're going to place our guide over the teeth. We're going to place our anchor pins into place, making sure we have everything in the nice position. And we're removing the rest of the teeth at this point in time. And this is where we're going to start reflecting the palatal tissue a little bit to relieve it some, then tie it off, and we're going to have our bone reduction. So we're starting our bone reduction here. We've got a occlusal view. If you take a look on the left-hand side, there's a little bit too much bone. How do we know that for sure? I always try in the PMMA transfer plastic guide, and if it doesn't clip in at this point and into the Swiss locks, then take it out and make sure you remove enough bone so that it fits in passively. Once you do that, you'll save yourself a lot of trouble in the future. So then we'll go back and remove a little bit more bone until we are able to get that to seat properly. And once we have enough of our bone reduced, we'll then place in our osteotomy guide, where we're placing our implants using a barrel system that doesn't require keys or spoons. I always like to rinse out the osteotomy with some saline from any debris. I undersize all my maxillary osteotomies, and I will place an implant into the osteotomy if I feel at least one size less than the final osteotomy, sometimes even two, because you're never really sure. And so when I get a feel for that bone, I want to make sure that we have the right torque into place. I want to have at least 72 on our ISQ when we're doing our readings, if at all possible. So we're placing our implants in the undersized osteotomies. Take a look here. I'll always do bone profiling afterwards. It makes it much easier from when we're placing our cylinders and the MUAs. We've got our penguin in place here, checking our ISQs. When we get ready to do our PMMA transfers, we're placing the multi-units in the proper position, as we can see with the guide in place there. We have our cylinders going into place, and then the rubber dams over the top of those. We're going to place the nice stoppers that Ro has been making for us. I think these are wonderful, make things a lot easier. And then just place our liquid acrylic around the edge and around the cylinders, being able to pick everything up. We take it out of the mouth. I will make sure that there is no movement. I'm sure everyone else does. I take my cotton pliers and make sure none of those cylinders move at all. If they do, we're going to go back and redo this over again. We can take a look here. We're going to be filling in all the voids. And then we're going back to the surgery. So my assistant at that point takes care of everything with the PMMA. They fill in everything. By the time I'm finished placing my healing caps on here and placing some bone around and placing some PRF and starting to suture everything up, they come back and everything's ready for me to go. We'll try it in. Everything's nicely sutured up. I'll remove the comfort caps from the implants right here and place the prosthetic in. It just slides right in every time. It's wonderful. But that assistant doing that has saved so much time for the conversion for us, because we're just able to suture up, and literally they get such pride in making sure that it's nice and clean, that they get everything looking nicely, that it fits properly, and then we get the patient biting into occlusion. Now I do all my patients, like I said, under IV sedation. We actually nasally intubate, so we're never able to get a true occlusion. We always bring the patient back to do an occlusal check within 1 week. Obviously, they're on a liquid diet at that point in time. So our post-op workflow is this. The patient comes in for a 1-week follow-up to make any occlusal adjustments and to assess healing. We're going to take pictures in the CBCT. Since they were under sedation, we don't take a CBCT at that appointment. The patient comes in for a 3-week follow-up to remove any existing remaining sutures, reassess the occlusion, and make sure the patient is following all the correct eating instructions. And then we'll usually take a set of pictures after that. So this is again our CBCT that we took. I know we're running out of time here. Finished up here. These are the pictures that we took at the 3-week follow-up. Patient's doing well. She's very excited about herself, and literally we didn't even tell her she was coming in for pictures, but she's already making herself look just more presentable. I mean, she's putting makeup on, she's putting lipstick. She feels wonderful about herself. She feels much more confident. She loves this. She's excited about doing the bottom and fixing it up, whatever it needs to be. I want to thank all of you. You're more than welcome to email me at adam@thefolekcenter.com. I appreciate all of you taking the time out today. I understand how we're worried with what's going on, and the hard part for us is that we just don't know where the end is. And so it's hard for ourselves, it's hard for our team, it's hard for our families. And, I try not to let the stress kill me, but and take over my life. It's difficult. I'm out there with you, and I feel for every one of you. Please stay safe, look after yourself, look after your team, and thank you very, very much. Is there anybody still on the line?
Dr. Folek, we are still here. We
Okay.
were going to do some Q&A.
Okay.
If you'd like, I found a couple of questions. If I can read them off, because I kind of narrowed them down, and then you could give the answer, if that's okay with you.
Yeah.
Okay. One of the questions was, when you make a denture pre-op to establish occlusion, et cetera, in other words, you're making a denture for the workup, not for the surgery backup, but for the workup.
Yeah.
Can you bill that separately, or do you bill it into the price of the entire chrome case?
I just bill that into the price of the entire chrome case. To be honest, so usually for the maxilla, at least, we're going to have a backup denture anyway. So I can just incorporate that as being the backup denture. And one of the things I didn't go over was that we have package prices, and I don't know if that's normal or not. My goal is to do as many of these as possible, and if I can bring down the price and do it with quantity and still maintain the quality, I love that aspect of it. But if we're not doing any major grafting beforehand, like a sinus augmentation, ridge augmentation, but if we're just doing basic grafting like what I showed you, maybe adding a slight I'll sometimes put a membrane and tack around it if I decide to at that time period, that's still all part of the package price, including the extractions. We'll bill all that out to their dental, and we'll get as much money from the dental insurance companies as possible, but they're required to do, they know what the package price is. And usually once you start adding all those different aspects to it, it comes out to be much more expensive. And our patients have been pleased with what we're able to do with that and how that works out. So I don't bill that as part of it, because usually I've included that backup denture as part of my package fee anyway.
Okay. Another question is, about 11 minutes ago, at about 12:48, you had a form up on your screen, and I think it was one of the forms your staff uses. But the question is, would you be willing to share, if a doctor emailed you, would you share a form that they saw on this website?
This one?
Yes, I think that's
okay. Yeah, absolutely. This is just something we came up with. I got to tell you, this is made. Your staff will love it. Now you have to be committed to doing it. And like I said, I go from office to office. So some offices I'm only there 2 days a week, and when I'm just 1 day a week, I'll go in there, and sometimes there'll be 10 forms with CBCTs. Please plan these cases out. Patient needs this. Please do this. And it'll take me some time to do it all. And at first I was annoyed about it, but you know what? Things have worked out so much better. And accountability is the key to everything. And the staff seeing that we're taking accountability for ourselves also makes it much easier when we're asking them to do a lot of the little tiny things. Because this is one of the little tiny things that we have to do that makes everything work out and successful. So yes, I can send that to you easily. I can send it to whoever wants it.
Yeah, if you want, you can just put your email back up on the screen, and they'll email you. Perfect. Thank you. I think really just the last one, and this will be, if you're familiar with this product, a doctor is asking, he says, great seminar, by the way, is Hybridge an alternative? Is it a good alternative? And Dr. Folek, are you familiar with the Hybridge product?
I am familiar with the Hybridge product. I think all of the products that are out there are good, that are doing this and using the CBCT and digital technology. All of these things provide us with the ability to be more accurate. I personally like the working with the chrome, and especially now, this last case that I mentioned to you, I told her she's going to be a double arch chrome natural. I was doing a lot of that on my own just by placing implants where I needed to be and getting some biotemps, but it took a lot of time, and I'm really excited about this. Going straight to implant at implant level without an MUA. I think everything has its place. And I think that the chrome natural is going to, once all the kinks are solved out of it, and I think they're almost there, it's going to make things, give us just another tool in our toolbox to make sure that we're able to present various options to the patient. I think that's the deal, and it's our job to know which is the right option for that patient. If a patient has a lot of bone loss, unless they're willing to pay a lot of money for ridge augmentations and tissue grafting to get them to an FP1 situation, which still cannot be guaranteed in a fully edentulous patient, but you can definitely get a really nice result in a patient that has maintained a lot of their dentition, then I think that's for us to decide. So I think hybrid definitely works. I think I have no issues with it, no issues with any of the other ones. I just find this to be very easy, and I find it to be very accurate. And I've been doing guided stuff since 2004. So it's my personal preference. I do want to suggest to everybody, you've got plenty of time now. Look at your 2019 production collections, figure out what you're worth per minute, and figure out the days that you worked, average those out, how many hours, and then let your staff know. You'll be amazed at what that'll do. They'll actually look and go, you mean every minute I'm sitting here waiting for the drill that you didn't bring into the room is costing me, $42 for me to go look around for that? That's a lot of money.
Good point. I think that's the last of the questions. I'd like to add just one note that two things. One is Roe is open for the doctors that are seeing patients, emergencies, whatever it is that you're doing. Our laboratory is open and here for support. And on a personal note, working with Dr. Folek for the past 3 years, his team and his systems that he has in place, which are needed when you do this type of volume of full arch restorations, has been really terrific for us, because the correct records coming in make our job much easier, and in turn makes his job easier. So the systems that he's talking about today are just infinitely important for for having full arch, especially a volume of full arch in your practice. So Dr. Folek, thank you very much for presenting today. We're grateful, and hopefully
my pleasure. Thank you for having me. And this is to let everyone know, this is number 6 in a series of 8 seminars being put on by Roe over the next week.